Lynn is the Coordinator, Health Disparities in the Healthy Communities Unit of the Nova Scotia Department of Health and Wellness. Lynn's work involves supporting the department, district health authorities, community health boards, and community-based coalitions and networks to collaboratively understand and address the social determinants of health. Lynn has worked in the fields of health promotion and public health for nearly 20 years. 20 years seems to be going around. Focusing on, and I'll still say 16, 20, focusing on multi-sectoral engagement to promote health equity, cultural diversity, food security, and healthy communities. Lynn's going to talk about health equity and cultural competence in the context of domestic violence. Lynn.
Good morning, everyone. It's wonderful to see you all here. It is my role today to bring to our discussions some concepts, some terminology, and really the big picture of domestic violence. We are going to be talking in depth about domestic violence and the healthcare system. Actually, the health system writ large, the acute care system, the primary care system, and the public health system. So when we say health system today, generally we're talking about the big health system. And we're going to do a lot of talking about the health system today. So my job really is to bring the big picture of domestic violence to our discussions, because although we do, of course, need to be concerned about our response in the health system, we also need to be fully aware of the broad factors that bring us to situations and circumstances of domestic violence. The underlying premise, really, of the forum is that domestic violence is a health equity issue. Violence, including domestic violence, are rooted in social and economic inequities. They are produced by, as Courtney has pointed out, historic and systemic injustices, and are a consequence, very often, of economic and social policy. They can, to a large degree, also be remedied by economic and social and institutional policy, including cultural competence and cultural safety in our health systems. Health equity means providing everyone with fair opportunities to have the best health possible. The terms health inequalities and health disparities are synonymous. What they mean is that health is unequally distributed across the population. So we know that population health is at the root of much of our work. Population health looks at the health of the entire population and the distribution of health across the population. So health inequalities and health disparities can be used interchangeably. However, health equity means something quite different. Health equities has very strong connotations of fairness, of justice, of equity. And health inequities occur when inequalities or disparities in health could be avoided, i.e. through social and economic policy, but they are not avoided. They then become health inequities. We're using today the definition of domestic violence in the Domestic Violence Action Plan that has been recently developed and referred to this morning. According to the plan, domestic violence is intentional violence, abuse or intimidation, perpetuated by one person against another in an intimate personal relationship. Domestic violence occurs between people where one exercises power over the other, causing fear, physical harm, and psychological harm. Domestic violence may be a single act, but it is often a series of acts. Those of you who work in the domestic violence field will be familiar with the cycle of violence. It's often a series of acts perpetuated by one person against another. Domestic violence can occur in any relationship, in same-sex relationships, for example, as well as opposite-sex relationships. However, women are primarily the victims of domestic violence and men primarily the perpetrators. Children and young people may experience harm by being exposed to domestic violence in adult relationships in their homes, or being the direct victims of violence, or both. So men, women, and children can be harmed in situations of domestic violence, and sometimes that harm is very great. It's even to the point of death. Families are affected by domestic violence. Communities are affected by domestic violence. Society is affected by domestic violence. Everyone is affected by domestic violence. There are some groups, as I've just pointed out, that are more vulnerable to domestic violence, including women. People with disabilities, both men and women who have disabilities, have much higher rates of domestic violence. Aboriginal women have perhaps the highest rates of domestic violence in the country, some 4 to 5 times higher than in the non-Aboriginal population. And Aboriginal women also often experience the most severe forms of domestic violence. Our research on women of color is not as good as our research in the Aboriginal populations, but certainly there is anecdotal information that suggests that women of color are also more vulnerable to domestic violence. People who are vulnerable to domestic violence are also vulnerable to other health inequities, including poverty, including mental illness, etc. And these are the broad factors that we often talk about in terms of social determinants of health: poverty, racism, colonial trauma, gender inequities, etc. There are some limitations, I think it should be noted, of the data that we have. Less than 1/3 of domestic violence incidents are reported to police, so our data are very much incomplete. There is emerging knowledge about violence in same-sex relationships, for example. Many of those relationships are hidden or undisclosed, and so the problem remains quite hidden and undisclosed in that population as well. So our evidence is somewhat limited, but we do know plenty. We know plenty to begin to act on and to continue to act on. We have been acting on issues of domestic violence in the health system and more broadly. There are very strong links between domestic violence and health outcomes. Violence and the fear of violence can increase health inequalities, can increase health disparities, and worsen health outcomes. In physical health outcomes, for example, we know that people in situations, victims of domestic violence, suffer injury, a great deal of injury, all different kinds of injury, and sometimes very severe injury. But we're also beginning to know more about the connects between domestic violence and chronic illness, because the experience of domestic violence can get under your skin. It can actually alter your body's functioning so that you are more likely to have chronic illness and to have lifelong illness that will carry with you even beyond the immediate circumstances of domestic violence. So those chronic illnesses are illnesses such as asthma, ulcers, stomach troubles, gastrointestinal troubles, diabetes, eating disorders, and neuromuscular diseases like fibromyalgia, for example. As well, domestic violence has widespread and very challenging and difficult mental health outcomes, including depression, anxiety, high levels of stress. Again, stress gets under your skin and is likely to make you sick. Very high levels of self-blame, of self-harm, for example, addictions and even suicide, are related to domestic violence. As has been pointed out, Nova Scotia has a set of guidelines for cultural competence in primary health care. We're very proud of those guidelines. In those guidelines, the cultural competence is defined as the attitudes, knowledge, skills, behaviors, and policies required to meet the needs of everyone in the population. So cultural competence is very much about health equity. And as Courtney pointed out this morning, First Nations and Aboriginal people are more likely to refer to the notion of cultural safety, which refers again to the competencies required to meet the unique needs and circumstances of First Nations and Aboriginal people, which include but are not limited to colonial trauma, the reserve system, which was a system of racial segregation, the residential school system. All of these systems enacted as a result of social policy. So again, important to take a step back and look at the policy context in which we are working and the extent to which that contributes to health inequities, such as domestic violence. These are some, by no means all, of the determinants of domestic violence. They are, I think, most of the critical ones. Starting at the top of that little figure, culture and ideology are really critical in the incidence and the maintenance of domestic violence. That is the realm in which the isms live: racism, sexism, heterosexism, ableism, classism, and these isms are determinants of health. Culture and ideology is the realm in which patriarchy lives, the idea that men are superior to women and should dominate women. That ideology of patriarchy has been entrenched in our societies for hundreds and I may maybe say thousands of years. and we still must deal with the implications and the outcomes of that set of beliefs and practices. Culture and ideology are closely linked, going counterclockwise around that graphic, to the economy and the labor force. We know that the liberal ideology that accompanies our market system is about individualism, it's about individual responsibility, and perhaps not enough about our collective responsibility for looking after one another. Labor force participation is a factor in health because it can lead to security, income security, or it can lead to insecurity around precarious employment, unemployment, etc. Again, these factors create stresses in people's lives. Culture and the economy play out in the structures and systems within which we live. These structures and systems are related to justice, for example, to education, to workplace and labor force, and to the health system. When I asked myself, when I was preparing this presentation, I asked myself, where does domestic violence show up? Where does it show up in our systems? It certainly shows up in the justice system because we have a set of rules and policies and laws related to domestic violence. But it also shows up in our schools related to learning problems and issues for kids. It shows up in our workplaces related to absenteeism, related to mental health problems, etc., that interfere with work. But perhaps most of all, it shows up in the health system. I'm thinking here of cases that are not, that do not go to the justice system. We know, again, that less than a third of cases actually go to the justice system and are prosecuted. So perhaps domestic violence shows up even more in the health system. I'm thinking here of the cases where people say, the cupboard door was open and I ran into the cupboard door. I'm thinking of cases where people come to their physician and say, thank you, and say, I fell down the basement stairs. So domestic violence shows up in the health system. So we have a real responsibility to respond adequately, comprehensively to the problem of domestic violence. Domestic violence occurs in relationships. So relationships are critical in domestic violence. And our support networks, or the people around us, can be both risk and protective factors for violence. They can encourage violence or they can protect us from violence. So those networks are really important. We know that children and youth are really important in domestic violence from the point of view that about 30% of assaults are witnessed by children and youth. And we know that children and youth who witness violence in their homes or are more likely to be involved in violence later on in their lives. And finally, I think it's important to note that there are very real rural and urban differences in response to domestic violence in terms of, for example, isolation in rural communities, in terms of the availability of services, and in terms of transportation issues that people face when they try to leave a relationship or to leave a community. So those are just some of the determinants of domestic violence. So to conclude, domestic violence is a health equity issue that requires a culturally competent and a culturally safe response within the health system at multiple levels. So again, I'm very happy to see you all here today. I hope you can take some of these ideas into your conversations. I know we're going to learn a lot from each other, and I think as we put our heads together, we can find ways to improve the health system response to domestic violence. Thank you.